Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. Lecture 9, Part 2, the prosthetic phase. So in Part 1 of the prosthetic phase, we basically went over a number of clinical pearls that we wanted people to understand prior to getting to Part 2. So in Part 2, we're going to predominantly talk about impression techniques. So now that these implants have been placed, they've been placed in the right spot, there's a nice plan in place in order to restore these implants. We've ensured from a surgical perspective the patient's doing well. From a osseointegration perspective, we've ensured that the implants have healed inside the bone. We want to now basically find a means by which to translate the model that's inside the mouth and accurately replicate this in some sort of a working model that we can take to our laboratories with a prescription and ask them to fabricate some sort of a prosthesis for us so that we can utilize these implants for the purposes for which we place them. So in Part 2, we're going to basically talk about a number of impression techniques that are out there. We're going to talk about the closed tray technique, the open tray technique. We're going to talk about digital impressions for those of you who are out there and curious about these wonderful digital impression techniques that are out there. The equipment that's out there, it's got somewhat of the what we said in previous lectures, the looks cool factor. So we're going to talk a bit about digital impressions and how they can be useful in a dental implant practice. We're going to talk about hex and non-hex impression copings. Number 5, splinting impression copings. Number 6, about verification jigs, very important. Number 7, also very important, verification radiographs. And lastly, a little bit about impression materials. So an overview is in terms of basically where we want to go from this point forward to the final prosthesis. Basically, is you want to have a master cast impression that's going to be taken to replicate the anatomy of the oral structures and their relationship to the dental implants. So errors in this step can basically be due to the inappropriate use of impression trays or inappropriate impression trays, different types of impression materials that were used, like say something that's too soft versus something firm, in which there's some sort of a lab error, different types of adhesives that can be used for these impression, different techniques as we covered previously, and verification of the seating of the impression copings as we're going to cover later in this presentation. You also want to verify the proper passive fit of the framework and the dental implants under prosthetic abutments. We covered a little bit about this in the previous lecture. We want to verify the proper shape of the prosthesis to provide adequate aesthetics and function, and also for proper oral hygiene for the patient. As we mentioned in the previous lecture, you don't want to give your patient a lunchbox prosthetic, and ensuring also that if a transitional was used, that it was replicated adequately. So remember, the nice thing about a transitional or some sort of a temporary or denture or prosthesis for a patient is that you basically gives you a chance to try everything out for the patient, to make modifications in this stage, and then more or less, if everything's hunky-dory, it's just a matter of copying your homework and ensuring that the final prosthesis basically matches that. So you want to ensure that there's some means by which to making sure that whatever was learned in this transitional stage is accurately replicated in the final prosthesis for the patient. Number 5, you want to verify proper occlusion after preloading and torquing of the prosthetic and or abutment crowns, and then obviously communication of acceptance by the patient. And some consideration should be given to maintaining access to the prosthetic or abutment screws, especially in extensive cases. So basically what we're talking about here is having a screw retained versus a cemented prostheses. And lastly, there should be some sort of a follow-up to see if function, comfort, and the patient has been satisfied, that the gingival health, phonetics, aesthetics, and occlusion have also been addressed for the patient. And one thing that I didn't place in here that you can obviously figure out that I'm going to advocate is some form of a bite plate as part of that follow-up procedure as well. So the closed tray technique. Let's talk about the closed tray technique. Well, for starters, we're all full of biases in our profession, so I'm just going to go out there and say I don't like it. We're going to talk about it because we have to talk about it for the sake of completeness of this presentation, but I personally don't like it. There's too many steps in using a closed tray impression technique. There's just too much room for error, too many parts, too many things that need to snap together, just too many things that, like I said, when you take permutations and combinations aside, when you start introducing too many steps, there's always going to be a room for error. So that's what I find with closed tray. It just looks like it's going to be problematic. It's a little bit better now than it was in the old days. In the old days, they actually used to have you screw the impression copings into the implant, take your impression and unscrew it, and then basically pop it right back in the impression, for which I was like, oh boy, how is this supposed to, how do you know this thing's actually going back exactly where it's supposed to be? Another problem with the closed tray technique is it's not necessarily the friendliest for splinting. Splinting of the impression copings, if you're doing two implants side by side for, say, a bridge, it's still possible, but not quite as logical as the open tray technique, as you'll see later in this presentation when we talk about splinting of impression copings. So to get into this, more or less, you can see in this photograph right here, just some cartoon depictions of a closed tray technique. So this is a little bit better than the old school style where you basically put your impression coping in, take an impression, rip the whole thing off the impression copings, and then unscrew it and pop it back in the implant. So this is sort of a two-piece system that they came up with. You basically take these little impression copings and seat these down onto your implants. And as you can see from what you see on the picture on the right, sort of splinting these together is not quite going to be quite as logical as you're going to see later on when we talk about splinting the impression copings for an open tray technique. You also want to take a radiograph to ensure that these copings are seated in the appropriate spot. And on these copings, you can then basically place these impression plugs, which basically sit down and they basically have a bit of an intimate fit. Once again, I'd recommend taking a radiograph in order to ensure that these things are seated in the appropriate spot. So once you've done this, basically it's just a matter of taking some form of an impression tray with some type of a heavy body impression material. I personally like using a squirt of light body impression material just for accuracy, not accuracy, but for detail of the adjacent teeth, just because it gives that much more provocative information to the lab. Some people don't advocate using light body impression material with implants. I am of the opposite. I like getting that accurate gingival contour, gingival shape information, and be able to articulate that to my lab with heavy body. If you've ever taken a heavy body impression of, say, your own teeth, pour it up and see how detailed it is. Doesn't quite look the same. So I like using a squirt of light body material, but in conjunction with heavy body, but some people advocate just using heavy body to pick up these impression copings. So once you've picked up those impression copings, it's just a matter of basically flipping it upside down. You can see that in this depiction right here, they're basically trying to demonstrate that heavy body impression material, you get this kind of detail. I've never seen a heavy body impression material give me this kind of detail. So usually you have to have some combination of just a squirt of light body and a little bit of heavy body, and a whack load of heavy body in these trays in order to pick these things up and get accurate soft tissue information as well. And then it's just a matter of unscrewing those impression copings that were inside the implants. And in this picture, you can see that they've actually taken those the little impression copings out of the implants, out of the patient, and now they put them into the fixture analogs. And basically, it's a matter of snapping those back into position and taking a bit of a soft tissue mask and pouring that initially around this model, and then finally completing the pour up with stone. And this is what you get. You basically get a model which sort of should accurately depict what was inside the mouth. And once you take those little impression copings off, you can see the picture on the right here. It shows where the implants are in position, and in an ideal world with no error. So problems that I usually run into in these cases is that when you're trying to pick up these impression copings, sometimes things will move as they're just plastic components. They are they can move to a certain extent depending on how your patient is and stuff. So personally, I don't like using them. If you want to try using them, and if you can use them and you can consistently attain accurate results, I'm terribly sorry for not being a fan of this procedure. But for myself, in my own practice, the open tray technique is basically the only technique that sort of is out there. So for the open tray technique, I will state this is my obvious bias. This is my favorite technique, or at least this is the technique that I learned when I was a third-year dental student, and I remember sitting in Lab 4 at the University of Toronto under the tutelage of my favorite prosthodontic instructor, Dr. George Zarb, and more or less this is the only technique that they taught us. The closed tray technique was something that was introduced much afterwards. As a bit of an aside here, I actually had a colleague of mine who practices in another city, and one time I was visiting his office, and he basically told me that the lab that he works with, they basically told him that he could take a impression of the healing abutment using a heavy body and light body, and then from that they would be able to figure out some sort of an implant prosthetic. And lo and behold, I was in the office and he asked me if I could sort of help him out in inserting this implant retained crown. And as you can probably imagine, there was a tremendous lab error in using that technique. And so I had to basically break the news to him, say, okay, well, this is kind of a different type of closed tray technique, not something which I would necessarily advocate or try to teach on my course. And so I had to basically try to convert him over to using the open tray technique. So it is my favorite technique. Yeah, it's a little bit more difficult. It's not quite as easy as, say, the closed tray technique, but if you want something that works, that's going to consistently give you accurate results, this is something that I have found in my practice works fairly well. So as I state in point number 2, it's easy to replicate over and over and over again. So it's basically, for me, it's that 3-pointer. It's that spot on the hard court that I'm able to consistently hit that shot over and over and over again. It's easy to visualize movement. And what I mean by this is if the patient moves in an awkward manner, or they bite down or something, it's easy to see where the impression coping has moved inside the mouth. It's not like one of those little plastic pieces that's sort of just sitting on an impression coping or an abutment inside the patient's mouth, where when it moves, you don't quite know where it moved inside the impression material. So in this case, it's easy to visualize movement as well. When you're unscrewing this open tray, the impression coping on the open tray technique, you can see if you didn't quite grab it and there's some movement in that regard. And so you have to take another impression, that the impression that you've taken of these, this fixture level impression that you've taken of these implants isn't going to be an accurate reflection. So you're not sitting there sending it to the lab and getting something back and then having to go through the explanation of explaining to your patient that there's been a lab error. Furthermore, having to send it back to the lab. Some labs will charge you exorbitant fees for these sorts of errors, or having to redo work. Sometimes it's their fault, sometimes it's your fault. In the eyes of some labs, sometimes it's always your fault, or even if it's their fault or your fault or whatever, you're responsible from a financial perspective. So it's important to ensure that whatever sort of information is being sent to the lab is as accurate as possible from our perspective, especially if you have a less than forgiving lab who basically makes you the responsible for the financial costs that are associated with errors. So going to point number 4, it's basically also easy to place fixture analogs. So you saw in the previous images, you basically have to pop those impression copings outside of the patient. So you're still having to go and engage something inside the patient's mouth. So it's just a lot easier to sort of have to unscrew one thing as opposed to popping things back and forth. So with the open tray techniques, there's different types of trays that you can use. You can use a stock tray. So we have these stock metal trays on the left, or a custom tray, as you can see on the right. The basic advantage of a custom tray is you end up using a lot less impression material. So if you don't get your impression material for free, like a colleague of mine, Dr. Mike Tala, who works in Gladwell Laboratories, he's always joking around that he gets his impression material for free from his lab. So he always uses stock trays. But if you don't get your impression material for free like him, you might want to try using a custom tray. Obviously, there's a cost to cost and time in terms of making these things. So if you factor all that in, sometimes it all adds up. Obviously, using a stock metal tray and drilling a hole on the top of it isn't quite going to be the most feasible thing. So you're probably going to have to use what we go to next over here, which is some sort of a disposable stock tray. And the Teledyne Waterpik trays are what I predominantly use in my practice. Now, there's going to be other trays out there. One practice I used to work in, they actually used to do a lot of Invisalign. I used to get the impression trays from Invisalign for free. So we used to end up just using those for our open tray impressions for dental implants. We won't try not to tell Invisalign that, but God bless them for sending those to us. But these Teledyne Waterpik trays work really well. The main thing you want to make sure is when you do have any sort of a stock tray or using a custom tray is that you do have an adequate amount of adhesive inside of the tray to ensure that whatever impression material you're using, in our office we use predominantly vinyl polysiloxane or polyvinyl siloxane, VPS, PVS, whatever you want to call it. Some offices like using Impragum. Internationally, if you're using other things, like hopefully you're not using the polyethers or the polysulfides, but if you want to try a VPS, it's a great tray to use. Just make sure you use the right adhesive, whether you're using a stock tray or a custom tray. So more or less the technique. So if you see this in this picture right here, we have a model with a healing abutment on for a patient. So in the next picture, you can see that they basically have taken in this case, it looks like a custom tray in which they've made a lot of perforations inside the tray. And basically they have an orifice on the top of the a hole made into the tray in order to basically allow the implant impression coping for the hole for it to basically stick outside, so that when you basically take this impression, you can clean any impression material off that orifice that engages that impression coping onto the fixture or onto the implant, unscrew it, and basically remove the whole thing as one piece. So you'll see a little bit better in a bit of the case that I present a little bit later in this presentation. So in this picture, you can see that they've taken the impression coping and they basically placed it inside the implant. The key thing with impression copings is this one, and you see in this picture here, is excellent. You want to make sure that it has these big grooves in it so that the light body or heavy body impression material can really grab this thing snugly, and there's going to be no movement. If you have two implants side by side with two impression copings, I always like locking them together with some sort of a rigid material. So my material choice is composite resin. As you're going to see in the splinting section of this video, there are other materials that are out there as well. So then it's just a matter of basically getting the impression material inside of the impression tray, seating it down. As you see in this picture here, you see why this is called open tray. Basically, that impression coping is open, and you can unscrew it once this material has set. So once the material sets, it's just a matter of unscrewing that impression coping. You remove the whole thing as one piece, and boom, there you go. Accurate impression. You know exactly where that implant is from a three-dimensional perspective. Hopefully, you've engaged those threads on that impression coping, and there's no movement in this impression coping, such that there's going to be no error in this step. And then it's just a matter of getting basically a fixture analog and screwing that in. As I mentioned, it's a lot easier to do this as one piece as opposed to having a bunch of moving parts. Taking the soft tissue mask, as you see on the right again, and pouring that up, and you have, once again, your working model to send to the lab, along with your stock abutment or UCLA abutment or request for custom abutment or prepped abutment or whatever you're going to be using in this case here, and basically ask them to send you back some sort of a prosthesis. So case presentation. So basically we have a 72-year-old healthy female who presents wearing an acrylic partial upper denture to replace broken tooth number 11. Tooth 11 has been broken at the gum line for some time. In this particular patient's case, more or less, she couldn't quite afford to get an implant, so she just had an acrylic partial for a while, but the time has come now that she'd like to have something which is a little bit more substantial. There's also no evidence of infection in this tooth. This tooth had basically been a failed endodontically treated with a tooth with a post, some sort of a core and a crown buildup that snapped off at the gum line. So as you can see in this photograph here, you can see a picture of the patient with the flipper in place. In the next picture, you can basically see a picture of what the tooth looks like. So in this particular case, it's not really an ideal situation for an additional post-core crown. Once you account for ferrule, the trauma that's associated with removing what type of post she has inside there and placing another crown, it's basically going to require crown lengthening surgery for this patient so that we don't impinge upon her biological width. This would basically yield a poor crown to root ratio for this patient. You could also consider other replacement options for this patient, like a traditional bridge. However, the lateral incisor in this particular case is not really an ideal retainer for a traditional bridge, especially for a central incisor. I'd consider maybe a fiber post and a direct resin composite as an intermediate for the patient if she wasn't a surgical candidate or finances were an issue for her. But in this particular patient's case, she came in to see us because she wanted to get rid of this, what you see in this next picture here, this removable flipper, and get something which is going to be fixed. So basically the treatment plan for this lady was to go through the process of consent, getting the proper records, diagnosis, wax up, that sort of stuff, putting her some sort of standard of treatment, make sure all the teeth caries, periodontal disease, all that stuff has been treated. Number 3, basically we're going to go with a traumatic extraction of this tooth, assuming that buccal plate is still intact. We can place an immediate implant, and then in this case there was a large gap or jump junction, so we do place some sort of a bone graft in for this patient, along with the platelet-rich fibrin. Or in this particular case, I think we used a collar plug for the patient because she was a bit needle averse, and she didn't want us to venipuncture her to harvest her blood in order to create the platelet-rich fibrin, and then give her an adequate amount of healing time. So in this case, we gave her about 4 months of healing time, and then basically provided her with a screw retained crown, and then as always, a bite plate and some sort of a follow-up for this patient. So in this photograph here, you can see the patient's tooth, which is broken off at the gum line, as retracted. In this case here, you can see we have basically atraumatically extracted that tooth, and you can see a nice coagulum inside that socket. And now basically we've placed a 5 millimeter MIS7 implant. You can see that large gap jump junction on the buccal aspect there, so that gets grafted. And in this particular case, we put the cover screw on first, then we graft it, and now you can see we have that collar plug placed on top. And my favorite suturing set, basically a figure 8 suture along with an interrupted suture to ensure that that plug or the PRF or whatever you put in there doesn't come out. We bring her back after 7 days to remove the sutures, and you can see that area is healing really nicely, that there is no buccal defect. On the radiograph on the right, you can see the implant has been positioned in the appropriate position such that when we are out to restore this, we're going to get a beautiful emergence profile, and there isn't going to be any sort of soft tissue issues for this lady. You can also see from the bone levels that the papilla are not going to be an issue for this lady either. So here's the lady when she comes back after 4 months. You can see that there is a slight inflection on the buccal aspect there. So we have had a little bit of buccal hard or soft tissue loss. We put an H incision inside there in order to maintain the bulk of our connective tissue. Given the fact that we have had that loss of tissue, we want to basically tuck that tissue inside. And basically you can see here we're exposing the implant. So we place an impression coping. So there we go. So this is what we're talking about here. So this is an impression coping. We place it into the implant. We take a radiograph to verify that it's seated. Very important step. Once we verify that it's seated, we basically get a Waterpik stock disposable tray of the appropriate size. Once we know that it's the appropriate size, we drill a hole in order to allow that impression coping to come out the orifice. We try that tray in, ensuring that hole is in the right spot for the impression coping. We fill up our impression tray with a combination, as I said, I like using a squirt of light body on the teeth and around the soft tissue for the implant, just to give the lab that much more provocative information, along with the heavy body. Once it's all set, it's just a matter of making sure that screw head is not covered in impression material. Very important. Just take your finger and wipe it away, and then we unscrew that. And as you can see in this next photograph here, you have a gorgeous impression with a lot of detail, because we use some light body along with this heavy body for this impression. Then it's just a matter of taking a fixture analog and adding that on, and basically putting a cover screw, or in this case a 3mm healing abutment, on for the patient. Taking a shade, sending that off to the lab. The patient comes back after a couple weeks, and we're basically ready to insert this case. So you can see that the tissue has grown in and around that healing abutment for the patient. So the first thing we do is we clean that up a bit, and we're going to have to clean up a little bit of the soft tissue. You can see the remnants of that H incision, see how it really sort of helps bulk up that connective tissue in and around the implant. We try the implant in as per the previous lecture. You basically want to make sure that there's passive contacts. You want to make sure that the implant is seated by taking a radiograph, and you want to check the occlusion for the patient. So in the end result, this is what you can see. Beautiful. So if you want to view a case presentation for a patient on taking an open tray fixture level impression, do go to this YouTube video here. It's on our channel. You can see it, and it'll go over things in a video format for you. So digital impressions, what are they? So these have been around for many years. Basically, if you go into any dentist who's been practicing since the 1990s and you check around the graveyard, you're going to find a graveyard of sort of digital impressions or milling units and things like that. Things like the Cataraqui 1, Cataraqui 2, Cataraqui 3, Cataraqui 3D. I'm not even sure what they have now, but these have been around for a long time. They have the looks cool factor. It's a neat piece of technology to have in your office. So how do these relate to the dental implant world? So the technology basically keeps getting better. So it's almost like every 3 or 4 years is a new $150,000 machine. Some slick salesman comes to your office and tells you, oh yeah, you do one of these every other day for the next 3 or 4 years, and basically it pays for itself. And my own experience, having been in practice now almost 15 years, I can tell you is that every time that payback period seems to come by, a new machine seems to pop up onto the market, which is just that much more better. So I'm not quite sure what the purpose of digital impressions is, or who quite benefits from it, whether it just be the company or the labs who don't have to necessarily deal with paying for as many shipping costs and stuff. However, they do have a place in the market, so we'll talk about that. So it does require an investment in equipment on your part, and it doesn't necessarily save chair time is another thing you have to consider. I personally do not think that they offer a better product for implant dentistry, but as I mentioned, you're welcome to try it. So the big boys on the market are basically 4 major companies. There's the Cadent iTero, the 3M ESP Lava COS machine, the Cataraqui by Sirona, and then lastly the E4D by D4D Technologies. And more or less what you have are these little scan bodies that you put onto your implants, and these scan bodies can be picked up by these intraoral scanners, and basically you get these cool depictions of where your implant is and occlusion and all types of other things. If you move to the next slide, you can sort of see that these things, so you can put multiple scan bodies in, and you take the corresponding occlusal shots and the patient in occlusion, and you get these really neat graphics that sort of are created for the patient. There's also other uses for these things as well. Some patients or some clinicians who do a lot of Invisalign or clear correct or other types of indirect braces, these things can be utilized in order to send information to these companies to manufacture trays or to manufacture intermediary treatments for patients. There's also conventional crown and bridge that can be used with these scanners. The major advantage they claim is there's no dye spacer that's required, so it's a more accurate, more intimate fit. There's some optional milling centers in which basically you have your staff creating crowns in the back room. Most of my experience with these milling centers is after 2 or 3 crowns, you got to clean these machines out. So like I said, it's not really saving you time. You still got to get your staff or somebody to go and do these things, and you still got to sit there and mark where the anatomy is and mark where the margins are. You still have to polish and glaze these things in your own office. So as opposed to having another operatory or a different a fancy sterilization center or a larger waiting room for your patients, you're utilizing a lot of room in your own office, expensive room, for basically operating a lab. And anyway, this is something you can consider. Some of the crowns that I've also seen that have come out of these machines, they're not necessarily the greatest. Some I've even said sort of kind of look just like glorified temporaries that we make in the office ourselves, as compared to as compared to some of the lab work that I get from some of my master lab tech colleagues. So hex or non-hex impression coping. So the key thing about using a hex or a non-hex impression coping, obviously something with a hex is going to engage the implant a lot easier, especially if it's really deep down in the tissue and boom, I'm in there. Now you take a radiograph in order to confirm that thing's seated anyway, but why would you use a non-hex impression coping? So the key thing here is angulation. If you have a hex impression coping and another hex impression coping at a different angle, and you say lock these two things together in an impression, you can basically guarantee yourself that it's going to be very difficult to remove this once the impression material is set, right? So if it's the case that your implants are parallel, yes, you can use hex impression copings and lock them together. But if it's the case that your impressions or your implants are not parallel, there's any degree of divergence at all, you have to use a non-hex impression coping. Now, for those of you who are like, oh my gosh, where do I get a non-hex impression coping? All I have is hex. I've got like 20 hex impression copings and I have this one implant. So you can actually easily create a non-hex impression coping out of a hex impression coping just by taking the screw out, right? Taking a handpiece and just cutting that hex section off. So I wouldn't advocate you take the whole thing off. Sometimes even if you leave like a half millimeter of that hex, it's not going to be a problem. You can still sort of like, TP the impression off. But if you have a very long, say, 2 to 3 millimeter hex that's engaging that implant with another implant that's way off angle, you're almost never going to be able to get that impression coping off, or you will, but there's going to be a significant error because the thing's going to bend in the impression material. So going to the next topic is about splinting impression coping. So basically the purpose of splinting impression copings is to get accuracy of the impression, and it decreases the incidence of lab error. So in terms of where the implants are in relationship to one another. The best for splinting impression copings based off a study was GC pattern resin. And the main reason it has the least amount of shrinkage, followed by the use of something like, say, light cured composite resin. And hands down, the worst was something like Triad, which is light cured polymethyl methacrylate. So in this picture here, you can see that somebody's placed a number of impression copings in a particular case. In this case, it's 6 impression copings, and they've been locked together with GC pattern resin. And you also have these little flutes on top in order to make sure that no impression material is going to be getting on top of these screw access holes for the removing these impression copings for this open tray technique. In the next picture, this is a picture of a patient of mine. See 8 impression copings placed in the patient, and these are locked together with composite resin. And I don't have a photograph using Triad just because it doesn't work very well. It's too much shrinkage, and you're going to end up getting not a very accurate impression for your patient. So verification jigs. So verification jigs, very similar to splinting your impression copings, is once you've taken your impression, you want to basically take a number of impression copings again. So in this particular case, there's 6 implants, right? Take them, put them in, take a radiograph to ensure that they're seated, and then splint them together just like you did for your impression. And this is going to be a verification jig. So you're wondering, what's the purpose of a verification jig? Well, the purpose is that once you've taken an impression and poured it up, you want to basically be able to take your verification jig and it should fit like a glove, right? And if it doesn't fit like a glove, there's a mistake somewhere, either in your verification jig or in the impression. So you're wondering what the purpose of this is. Well, it's always important to make sure that the verification jig ensures that the model that you have is an accurate depiction of what's inside the mouth before you go out and spend a couple of $1,000s getting something like this made, like a CAD/CAM bar, and you all of a sudden you try it inside the patient, you realize, oh boy, this thing doesn't fit. Well, as I mentioned previously, labs aren't usually the most gracious when it comes to having to redo things. Now, if it's their mistake, you can tell them they have to pay for it. But if it's your mistake because you didn't have a verification jig, you're going to have to end up basically eating the cost for this. And as we discussed in previous lectures, surprises in implant dentistry are never a good thing. So we try not to have any surprises in this manner as well. Going to the next slide, basically talking about verification radiograph. So the purpose of a verification radiograph is to ensure that your impression coping was seated. So you can see in the picture on the right that the impression coping is not seated. See, there's a black line between the actual fixture and the impression coping, with that corrected in the picture on the right. The purpose of this is, if it was the case that you were to take an impression like this would basically falsely indicate to the lab that the implant is actually more coronal in position than what it actually is. And you're going to get back a restoration that's going to be not just both inaccurate. You'll probably have some difficulties with the contacts. Once you address the contact issue, you're going to find that the occlusion is going to be probably off by 1/2 to 1 millimeter, and you'll be doing a lot of work in that regard. So it's important to make sure you take these verification radiographs to ensure that these impression copings are seated, because remember, you're trying to take an accurate picture of the clinical scenario and replicate that in a model that you send to your lab. Lastly, we're going to talk a little bit about impression materials. So more or less, there's tons of impression materials out there. As I mentioned, there's the vinyl polysiloxanes, the polyvinyl siloxane, the Improgum, the polysulfides, the polyethers. You can even use alginate, though I wouldn't advocate you use alginate in implant dentistry, except for maybe perhaps if you're taking a mold of an opposing arch. So in this picture here, you can see just some 3M vinyl polysiloxane impression material along with the appropriate tray adhesive, whether you're using a disposable tray or a custom tray, as we talked about previously. And in this picture here, basically you see a polyvinyl siloxane impression using light body, heavy body on the left, and the accuracy of the information that comes from that as compared to an alginate impression. And the basic reason I've thrown these sort of out there is that when you're fabricating different things, you have to ask yourself, what is going to give you the most accurate, most provocative impression for the laboratory. So, if you're just making a sports guard, okay, or a night guard or something like that, maybe an alginate impression works. But in the next slide here, if you can see, if you're going to be making something like, say, an orthotic for a trial of a patient in a new vertical dimension, or even something like your final prosthesis, you probably want to be using something that's going to be a little bit more accurate than, say, alginate, as compared to the picture on the right, just making something like a splint or some sort of surgical stent for a particular case. So the next lecture basically is part 3 of the prosthetic phase, and we're going to actually go into different types of prostheses and go over a number of case presentations. So as with all lectures, we've included the references that we used in the production of this lecture series. So on behalf of the entire dental treatment team at the Cataraqui Woods Dental Implant Institute, I want to thank you for listening to our lecture.